From ARUP Laboratories on the campus of the University of Utah, welcome to the LabMind podcast. I'm your host, Dr. Brian Jackson.
Today is Wednesday, the 13th of August, 2025. I am absolutely thrilled today for this interview. I was able to schedule a remarkable individual who has what I consider to be a very important perspective on laboratory diagnostics. Cherise Shockley works as a digital and social media manager, and particularly she works in diabetes advocacy. I met Cherise at last winter's Lab 2.0 conference in Chicago, where she delivered a presentation that I found both compelling and frankly somewhat challenging to our industry in terms of what we need to think about. Cherise received her bachelor's degree from Arizona State University's Walter Cronkite School of Journalism and Mass Communication, and is currently pursuing a graduate degree in digital communication from Liberty University. Cherise also served for 6 years in the U.S. Army Reserves. Her newsletter is entitled Diabetes Social Media Advocacy, and you can find that and subscribe to it on LinkedIn. Cherise Shockley, welcome to LabMind.
Hi, Brian. Thank you so much for having me.
Let's start with your personal diagnostic journey.
Ooh, that's a loaded story. Do we have enough time? Okay, so I will make it short, sweet, and to the point. I was diagnosed with latent autoimmune diabetes in adults back in 2004 when I was diagnosed. People had no clue what it was. So now I'm going to back up and I'm going to tell you the story. My husband just came home on leave from Iraq because his grandmother passed away. This is another symptom of diabetes that people don't talk about. I had a yeast infection that I could not get rid of. I went to the Troop Medical Clinic because my husband is active duty. And she looked at me. She was like, "Are you pregnant?" I'm like, "No, I'm not." She was like, "Have you lost some weight?" I'm like, "Yeah, lost about 5 pounds." She was like, interesting. So got back, saw the nurse practitioner. She was asking me medical history. "Do you have diabetes?" Blah, blah, blah. I'm like, "No, I don't." She's like, "But I'm curious. So let me check your blood sugar." So she checked my blood sugar. And my blood sugar read 350, I believe. It's just like, "You have diabetes." She's like, "But it's kind of weird because once again, back in 2004, you don't fit. You're not overweight like someone with type 2 diabetes, but you're too old to have juvenile diabetes." She said, "So I'm just going to send you home with a meter. I'm going to run some labs and I'm going to see what's happening." She called me back when the labs came in. And she was like, "I have never seen this before. You have a functioning pancreas like a type 2, but you have antibodies like the type 1. I'm like, "Okay, I don't know what that means." She said, "This is what we're going to do. I'm going to send you to an endocrinologist. He is the only endocrinologist right now in the state of Missouri that is doing pancreas transplants." And I'm like, "Oh, okay." I went to the appointment and he said, "I think I have an idea of what you may have. But I'm going to tell you this. Although those boots look nice, you're going to have to wear smaller heels to protect your feet." He went in, he asked questions. He said, "I don't really like how your blood work is read, so I'm going to send it through our lab." He was like, "So I'm going to take 14 vials of blood and we're going to go from there." Took the blood, came back, of course, a week later. And he was like, "My suspicion was right. You have type 1.5. And I'm like, "Okay, what is type 1.5? Which is late autoimmune diabetes in adults." And he said, "Well, here's the deal. Your pancreas can stop producing insulin tomorrow. It could be 10 years from now. It can be 5 years from now. I have no clue what's going to happen. However, I need to give you something so we can help you manage it." So I was on a 0.5 milligram of a pill and it worked just fine. Going through life, my mom's telling everybody, "Hey, my daughter has type 1.5. "Oh, she doesn't. That doesn't exist." I'm like, "I'm telling you, I'm not making this up. This is what I really have." So in a nutshell, that's pretty much my diagnosis story. I will tell you though, when I was diagnosed, I made a point and I made a promise to myself that I would not become a victim and that I would take and manage my diabetes seriously because even though, as we know, right, and research continues to show, sometimes people that do not manage their diabetes can still live a fruitful life and they won't lose any limbs. That's their genetics. So I wanted to be able to say that I did everything I can if I were to receive a complication. Because one, being a Black female, we're susceptible to everything. So at that point, I was like, I'm not going to let this happen to myself. So that's my story.
Now, I have to confess, before hearing your story, I was not familiar with this variety of diabetes either. So when you say that people don't believe you, I can sort of see how people haven't heard of this. Do you know how common it is?
So Brian was actually fascinating about it, and it's pretty sad. So I was diagnosed in 2004,
Mm-hmm.
and I couldn't even find information about latent autoimmune diabetes in adults at all. There was one website that had information about it. I think it was the Islets of Hope or something like that. But JDRF, ADA, no information.
They were just talking 1 and 2.
They just 1 and 2. So I'm gonna answer your question, but I have to tell you this funny story. The funny part about that, Brian, is that I ran across this diabetes online community. At the time, it was called Two Diabetes, and it was ran by one of my good friends, Manny Hernandez. And he actually had type 1, type 2, type 1.5/LATA. I immediately joined that community because he recognized that what I had existed. So to answer your question, it's not as uncommon as you think. The problem is the misdiagnosis based on old stereotypes and perceptions of what people with type 2 should look like, right? So case in point, she said, well, you don't look like someone with type 2 diabetes, and you don't fit that age range of someone with juvenile diabetes. So about 10% of the type 2 population actually have what I have. The only problem is because they don't fit in the box and they respond to treatment in the beginning,
Yeah.
then they just get put in that type 2 box until that treatment and they're not responding. So then there's two things that happens. You have someone who is trying their best to manage their type 2 diabetes. They're eating well, they're doing everything, but it's not going to work because they have LATA. The reason why, like I said, it's misdiagnosed is because of the stereotypes and the stigma that's associated with it. So I think that it would be nice to have a C-peptide test drawn. What is and then your GAD-65 drawn for people who was responding to treatment, and then a few years later, they don't respond. Instead of making someone go through that, oh, it's my fault, I'm going to hurt myself. I think that people who work in the clinical lab, especially because you see history, right? You have that knowledge, especially if that person is coming to your lab, into your health system consistently, you can see the ebbs and flows of things that could possibly be happening.
So it sounds like the diagnostic process for you actually worked out pretty well, but it sounds like a situation that may not have always worked out well for people with your particular disease.
You're correct. And it's funny because back when Twitter was the place to be, I met a lot of people online, and there was this one friend, Brian. She was older, white lady, and she was like, I'm trying everything that I can, and I cannot get my blood sugar down. My friend was like, this is weird. And I'm like, wait a minute. I bet you 110% that you have what I have, which is LATA. And she was like, okay, well, I'm going to go get labs. So she changed doctors. She went to the University of Kansas, and she was diagnosed with latent autoimmune diabetes in adults. And I can't tell you how it happens. So to me, another indicator is if you have a kid who has type 1, you get diagnosed with type 2, right, later on in life, because the first question people ask you with diabetes, type 1 or type 2, do you have a family history? Most people, the answer with type 1 is typically no, right? You do have a lot of outliers. But then the reverse question to me for people with type 2, do you have a family history of type 2 diabetes and or LATA, and how close is that to you? Because, for instance, my husband, he has type 2 diabetes. My bonus daughter has LATA. What a fluke, right? So it's almost like when I see changes in his treatment, the first thing I think is, okay, you've lost a ton of weight, for one. Secondly, you've never really been what the world considers to be obese. You might want to go back and get labs redrawn to really confirm that you truly have type 2, because you could have been honeymooning this whole entire time.
Your story really speaks to both the high stakes and the, let's just face it, the imperfection of medical diagnosis, that there are misdiagnoses out there. Fortunately, I guess yours was a case where laboratory testing was able to clarify the answer, but someone had to know to order those tests. And it sounds like that's not always the case.
Or even understand what they mean. So if we go back to the nurse practitioner, she was like, I've never seen this before. And that's a military treatment facility. I'm blessed in the fact that I have great insurance. I could get the best of the best. And I could call TRICARE and say, hey, I need to change my PBM, or I can get referrals approved. And a lot of people aren't fortunate. A lot of people also, Brian, they're not well versed in diabetes, even just as people living with it. It's a health literacy thing that I think happens not even just with people, but also medical providers, especially some medical providers are very old school textbook. So if they've never seen it, never heard it, to me, their pride is like, okay, well, even though you may not fit the bill, I'm still going to say that this is what you had because you're between this age, and that's not right. Or on the flip side, I have a lot of people that they're nice and healthy people, but they lived for years thinking they had type 2 diabetes, and then they found out they had LADA. It happened to Lance Bass from NSYNC recently, right? He thought he had type 2 diabetes, and he found out he had LADA.
Let me pivot a little bit. When you spoke in Chicago, one thing that caught my ear was your perspective on terminology. Now, when we talk about healthcare, the people on the providing end have a lot of names like doctors, nurses, nurse practitioners, and so on. And the people on the receiving end, we doctors like to refer to patients. Many doctors are very uncomfortable with other words like consumer.
Mhm.
What's your perspective on this?
Oh, that's a good question. While we're on terminology, first, if you have a person with diabetes, they are not a diabetic. They are a person living with or a person with diabetes. We carry too many labels in this world as it is. Calling someone a diabetic, they can call themselves whatever they want, but as healthcare providers,
Yeah.
we're not diabetics. We're people with diabetes.
Is this partly an issue of putting people into boxes? Is that what you think the word does?
Sticks and stones may break my bones, but words will never hurt me, right? That's not true. It's more of sticking in a box. It's about language matters. So
Yeah.
compliant versus compliant.
Yeah. The word compliant is really dangerous.
Notice I never said, I use the word manage diabetes. I don't say controlled, because we all know diabetes has so many different facets to it. It's not just what you eat. You could be going down the turnpike at the airport and your blood sugar goes up. It's so many factors that a lot of people don't understand. So let me come back to what you asked me. The question around the word patient and consumer. So I'm going to give you some clarity. This is my personal take. So I am an N01. If I am seeing a medical professional, then I am your patient. But if I am receiving services from you by way of something else, I am not your patient. I'm a consumer. So if you're not my medical doctor, you're not my dentist, you're not my doctor. Now, if you work in the lab, you're a doctor, so you can call me a patient. But for instance, my CGM company, I am not a patient of my CGM company. I am a consumer. I am a customer.
So what's the implication of that?
Because they don't treat me. They don't do anything for me. Their medical device is a diagnostic tool that helps me manage my diabetes, but I can't call my CGM company and say, I'm having issues with my blood sugar. They're too high. So can you give me a SGLT2 or a GLP-1, or can you lower my dose?
Mm-hmm.
They don't get paid to do that. My doctor's office does.
Let's talk a little bit about the cultural history of being a patient and being an engaged consumer. It seems to me that historically, the role of a patient was seen as more passive. And I think maybe that was a little self-serving on the part of the medical profession. Do you think that the culture is changing? Do you think that the healthcare world respects people to have a more active role in their care? Or what's your feeling of that?
I think it depends. And I'm going to give you an example. So my husband and I, we have the same medical doctor. He's amazing. But he knows how active I am in the diabetes space. So when my husband got diagnosed with diabetes, even though my husband knows a lot about it, he gets it. It's not his thing, so he don't talk about it. So when my husband was diagnosed with type 2 diabetes, his doctor talked to me and not to him.
Interesting.
My husband is very articulate and intelligent, but he talked to me to ask me what I think is best for him.
Interesting. And how did that leave your husband feeling?
He was upset, but that's not even the worst part, y'all. The worst part of his diagnosis is that you're going to give him metformin,
Mm-hmm.
and you are not going to give him a glucose meter for him to understand what's happening and how metformin may or not be affecting his body. That's another issue. So I'm sitting here and I'm talking to the person who's scheduling the appointment. And I said, hey, he can't go home without a meter. This is not going to happen.
Mm-hmm.
And she said, okay, but usually we don't do all that until he sees the diabetes educator. I get it, but what if he has an adverse effect to this? How do we know what's happening? And she was like, okay, we'll give a meter. My next question I asked, how many times do you want him to check his blood sugar? And she said, whenever he wants. And I'm like, this is why people with type 2 diabetes think that it's not a big deal, because you're telling them it doesn't matter. I was like, so I looked at my husband. He looked at me and he was like, hey, I at least want to check this twice a day. I need to understand what's happening. If we weren't married, he could have said all that himself without me. But how many people have a Cherise or has a very informed patient or a consumer that can go head to head and call doctors in politely, right? So yes, Brian, a lot of this is on the doctor and can be partially on that clinical laboratorian, right? But as a person with diabetes or a person with any medical condition, you have to care. And if you don't care and you don't invest in your care, even when the system is set up to fail you, you got to keep fighting because they want you to stop fighting, and you shouldn't.
An interesting part of your story is this relationship between engaging with a disease and having a tool like a glucometer to help you engage with it. With most chronic diseases, there are some kind of laboratory tests that are used for monitoring along the way. And it seems like without having those tests available, the tests themselves could play an important role in an individual engaging with their disease. I'm not putting this very articulately, but does this make sense?
I know exactly what you're going to say. I'm going to frame it in a way that answers your question. I'm going to do it from a clinical point of view. So, Brian, yes, to answer your question, I have all the tools, the gadgets, right? I have the CGM, I have the insulin pump, I have everything. But the problem with that, Brian, is that my CGM is not connected through my EHR, my CGM data. So my endocrinologist has to have a separate sign-on. I have to give them permission to get access to my CGM data, because although right now A1C is kind of like that golden ticket for people with diabetes, that's going to change where A1C and time in range, and you're going to start to see the shift are going to go hand in hand. But if the CGM data can't be integrated into my EHR, then my endocrinologist staff has to stop what they're doing, sign on to another portal, then take that information that could easily be added and dictate and write notes on it. To me, that's a problem, because what that could actually do as a clinical laboratorian, right? if you had the A1C and you can see all my other results, right? My kidney, everything, thyroid.
Yeah.
But what if you could see my time in range?
Mm-hmm.
What if you can say, you know what? I noticed that this is what's happening with this person's time in range. Could you develop with the influx of people having type 1, Latin, type 2, PCOS, whatever you want to call it all? Could you all be that partner that can take some of that pressure off? Because we know that there's not a lot of people going into the endocrine field. So a lot of that pressure is being put on primary care, family doctors, and then this thing about rural areas, right? Where somebody has to drive 2 hours to get to an endocrinologist for labs. So my question is it even possible if we're trying to get from the quantity to the quality and we're trying to really focus on the quality of life for people? A proactive approach will help us stop so many things from happening before it costs people out of pocket costs, healthcare systems, mental health, right? It could save a lot. So for me, I think that partnership, I don't know who can put it together and figure it out, but I think that with them being so busy, seeing so many patients, could it just take all those and just marry it together and acknowledge, hey, this person's on track, but I noticed the change. And if you take their CGM data and you overlay it with that A1C, it's going to tell a better story.
It really feels like diabetes is at the cutting edge of where a lot of medicine needs to go. Because with these CGMs, these continuous glucose monitors, you don't have anything like that for most diseases. But for diabetes, it's this huge volume of really informative data. But then, like you say, it totally breaks the model that we've designed around lab testing, because lab testing is designed to occasionally have you drive to the draw center, get your blood drawn, get sent to the lab. This is not a continuous process. Continuous glucose monitoring is not just cool, but practically speaking, it really does give you a lot more information, like you're saying.
It gives us a lot of information. So I used to work for a diabetes nonprofit. And let me tell y'all something. I am a very informed patient slash consumer.
Mhm.
And the amount of information that I learned about the CGM and the actual charts and graphs and all of the bad things that most people don't pay attention to, it's fascinating. The A1C, it was great and it's good to go along with, but it can't allow me to have a conversation with my doc. And he was like, hey, what happened here? And it's like, you know what? I just started my graduate program and I just been snacking a little bit more. And he was like, okay, because your A1C, I said, I know it's a little high because this program is 8 weeks and I'm stressed out.
Right.
So it allows me to have open dialogue with my doctor and not feel judged, because to me, that A1C is like, oh, your A1C is high.
It's a judgment. Yeah.
It's a judgment, but if used properly, allows you to have those open and real conversations with your doctor.
That are much more specific
Mhm.
and frankly informative, it sounds like.
Correct. For instance, I just went to the endo and he sat down. He didn't even draw my A1C. He just took my CGM data and he said, okay, I see what's happening. You're not titrating your medication, right? So we're going to get you to titrate it. But case in point, we talked about my CGM data. We didn't talk about my A1. He said it was high because he could see that based off the CGM data, that prediction of what it could be.
Yeah.
But for the most part, he never drew the A1C.
Because you didn't need to, because he had better information from the CGM.
Yeah. So if we could get more people, not even just people with type 1, because we're still, that whole type 1 population and the subsets within it, we're still very tiny compared to the type 2 population. So as the world starts opening up and there's more research on, which to me is insane that you would have to have a research study to get an indication that an insulin pump or a CGM should be approved for use for people with type 2 diabetes. Makes no sense. Same thing. Don't get me on GLP-1s and SGLT2s, because people with type 1 they also have insulin resistance, just like people with type 2 diabetes. So I think that it's crazy the hoops that the medical system makes you go through. Me and my husband, we joke a lot. We call people with type 2 diabetes more the silent majority because they don't really make as much noise as people with type 1 diabetes. But now that silent majority are getting seats at the table, which it should have been that way a long time ago, because proactive care saves lives. Reactive care is just a hot mess.
Yeah. So one message I'm hearing from you is that the laboratory diagnostics world, and I'll say that pretty broadly, really needs to take a serious look at the implications of things like continuous glucose monitors, because we really need to move away from this paradigm of occasionally sending a tube of blood to the lab and find more and more ways to do continuous monitoring in your real life without you having to come to a draw center. I realize that's not going to happen immediately, but
Brian, yes, I agree. But you bring up another great point, right? So I have a great job. I have an amazing husband. My medical care, like I said, because of his service, is pretty much practically taken care of. The cost of CGMs are, whew, they're expensive. There's always going to be people that are going to have to rely on the A1C. But what are other things can we do? Can you get someone hooked up with a meter that talks to their cell phone? There's a really cool app out there called Glucose Guide, where you have this community of people with diabetes. They get together weekly to have these conversations. But now the improvements on this, so you import your data, you do all of these great things. But how can that data, once again, be included in the EHR? And granted, it's not continuous, but it's another touch point that could help with various predictions. Infections, you can say, oh, this person, for me, like if I had diabetes, I had a yeast infection back then and I had a CGM, I would know something was immediately off. I think the medical system and the laboratory system as a whole has to figure out how to stop making things so difficult.
yes, definitely.
And it's like anything, right? There's way too many processes. My question is for you, and I know you can't answer this, but what if CGMs was approved for everybody with diabetes and A1C went bye-bye? What does that mean for the lab? Because type 2 diabetes is like a pandemic in itself because we see it slowly coming.
Yeah.
But are you all set up for that?
One thing that comes to mind is something that you were talking about earlier when you talked about integrating one type of diagnostic data with other types of diagnostic data into a big picture. I think part of the answer to your question is that just from a technology perspective, probably only some kinds of things are going to turn into continuous monitoring in the foreseeable future, even though it'd be great if everything could turn into near patient monitoring. But the other thing that you brought up, I think, is just a really interesting idea. The role of the lab historically has been to run individual tests and issue individual results. And basically, it dumps it in the lap of the doctor or the provider to correctly make sense of it all.
Okay.
And I love your idea that laboratories could potentially play a role in providing that data back in a way that actually made more physiologic sense than just a list of individual numbers. At least that's what I was gathering from what you were suggesting.
Mm-hmm.
Let me change gears to a related topic. A couple of years ago, I was living in London, and one of the big pharmacy chains is called Boots Pharmacy. So I'd walk into a Boots Pharmacy, and in most of them, they would have a stand right at the front of the store advertising lab tests that you could order on yourself. And obviously that interests me as a pathologist. But here's the thing, they were being promoted more or less the same way that a pharmacy might promote vitamins, in very vague terms. So you'd have a men's wellness panel or a women's wellness panel where they just bundled together a bunch of standard things with maybe a TSH and an A1C, but they were being presented to people in wellness terms rather than medical terms. If you're going to offer lab tests to people without a prescription, why not give them the whole menu? What do you need to dumb it down? Because frankly, most people need testing for specific reasons, not just so they can make themselves feel better about their wellness. There's usually a reason why you get a lab test. And it might be symptoms, it might be your history, it could be a combination of things. Does that resonate with you?
If it was possible, and if we take diabetes, for instance, when my daughter was younger, every time she would get sick, the first thing I would do is check her blood sugar. Instead of paying $25 copay for her to go to her primary care physician and say, hey, just so you know, I have diabetes, my husband has diabetes, can we just check her blood sugar to rule it out?
Mm-hmm.
So to be able to walk in a clinic and say, let's check her blood sugar and let's just run her lab because we know our family history, that would be very interesting. And I wonder how many people would take advantage of it. But then the next question is the cost. Because I know if I go to the wrong lab, that's not my health insurer, I get a big bill. So I would say if it was affordable,
Yeah.
then yes, because I think there's a difference between access and affordability in America. We have access. So if I could not afford my insulin, I can go to the ER, at least get by for a certain amount of time. Whereas being able to afford the insulin is totally different. So I would say for me, what is that affordability for those tests? And because everything is a market, right? Sick people is sick care. I think I heard it at Clinical Lab 2.0. Sick people care is profitable. And let me rephrase that because I'm not saying that you all said that or the attendees said that it's profitable. It was more of a comment of the state of affairs in America.
Let's face it, I think everyone listening to the podcast knows healthcare in America is really expensive.
Yes.
I'm going to be careful with my words, but a lot of things in a lot of situations end up with very large markups.
Let's stick there for a quick second because you are right. So once again, I'm just taking my own personal experience. I found out that when I went to the doctor, the endocrinologist, she was like, hey, do you need some sensors? You need this? I was like, yeah. She's like, well, I'm going to send this to the pharmacy. And I'm like, wait a minute. I know I can get them to the pharmacy, but what does that cost me? So when I went to Walgreens to pick up my CGM sensors, for a 3-month supply, it was only $75. But if I were to go to a durable medical equipment supplier, it was $158 for a 3-month supply.
Oh, yeah. If you need a wheelchair or a pair of crutches and you get a prescription for it, your copay is probably going to be 3 times as high as if you just get the same thing on Amazon.
If you could have that quality of care with the same type of service, knowing that it's a clinical lab professional in the back of that room, as you said, at Boots, where they could do that, then it'd be a different perspective, right? But also, too, I know healthcare is not cheap. So I know that having 5 Brians behind that door running those labs is going to cost something. But I do think as we move into more of direct consumer, whether it's diabetes or pharmaceuticals or whatever, I think there's going to be a balanced approach. I think back in the day, you used to call it concierge service, where you pick and choose the route you want to go. We're seeing more and more of that, even with the CDMs now, right? You can get them at Best Buy, even if you have type 2 diabetes, right? But say that you can't afford your sensors as someone with type 1 and you just need a quick fix, what you're going to do. So I think that as we continue to move towards consumer space, it's going to be very interesting on how people get creative. But again, everything comes at a cost. How much is this going to cost me in the long run?
In your introduction, I mentioned that you've done a lot of work in diabetes advocacy. What do you see as the role or the importance of communities for people living with chronic conditions?
Oh my gosh. So when I was diagnosed in 2004, I thought I was just the only person. I joined 2 diabetes, and you would think that I was having an affair on my husband because I lived in that community for hours upon hours. And then I was like, oh, I want to start a blog. And then, oh, I want to go do this. And meeting people with diabetes, back then it was amazing. This generation is a lot different. I'm going to break it down to you. When I was coming up in the online advocacy space right there, where in the diabetes online community, it wasn't well respected. It wasn't looked at by healthcare professionals as a safe place for patients, right? Because they believe, quote unquote, that you're going to get bad information, which you can do that. But you can get misdiagnosed at the doctor's office. No one ever calls that out.
Absolutely.
So for me, I would say that my generation, which we call it the OG diabetes online community, our purpose was so different. We wanted a seat at the table. We wanted to make sure that the box on a meter didn't always read 100 because our blood sugar is not always 100. We wanted to make sure that we had say in clinical trials. We wanted to make sure that, for me, my main goal was, as a person who's lived in both worlds, type 1, type 2, that everybody was included in the work that these companies are doing. And Brian, I did a lot of stuff where I didn't get an honorarium, where I took time off from my family so much that my daughter, when she was 4 or 5, she was like, I want diabetes because you have a lot of cool friends, right? That's how much time. My husband was like, you're using your vacation time. I'm like, babe, I have to go because, one, I have to do what I believe that God is like, you need to take this mess of a diagnosis and turn it into your blessing. And I want you to give back. So I gave back. I gave back without wanting anything. My goal, even when I started my Twitter chat back then, it was the only one for people with diabetes. And we had people from Canada, Australia staying up for this chat, and to see the reaction from them meeting people and then having blog talk radio shows where perfect strangers will call in, it's priceless. So that generation is different because we didn't get paid by the number of hits or the number of people that clicked. We were seen as thought leaders in the space. I noticed that shift changed one time where, being a patient advocate actively, I got an honorarium for the first time. And I was like, oh my gosh, this is so cool. Okay, welcome to the new world of patient influencers.
I love it. Cherise, thank you so much for coming on. Your experiences, the things that you've done with this community, the way you think about it. I think these are really important things for us to think about in terms of where the diagnostic world is either going to head in 10 years and 20 years or should be heading in 10 or 20 years. So thank you so much for being on LabMind.
Oh, you're very welcome, Brian. One last thing before we go. Just make sure when you all are making those decisions, make sure you have patients at the table.
Thank you for those final words. I appreciate it. Cherise Shockley, thank you for being on LabMind today.
You're very welcome. Thank you for having me.
LabMind is sponsored by ARUP Laboratories, a not-for-profit enterprise of the University of Utah and its Department of Pathology. Our producer is Cherie Peterson, with audio engineering by Isaac Acosta Alvarez. You can also find other LabMind episodes at arup.utah.edu, along with an extensive video lecture library providing free CME and CE credits for medical and laboratory professionals. Subscribe to LabMind on Apple Podcasts, Spotify, or your other favorite podcast app. And please leave a rating and review in order to help others find the podcast.